Welcome back to Visions for Health. My guest today is Dr. Gary Gross, medical doctor, fellow of the American College of OBGYN, as well as an instructor for the Harvard Medical School. Dr. Gross, welcome.
Thank you.
Thank you for being here.
My pleasure.
You have a long expertise in fertility and reproductive endocrinology, so can you tell me a little how you got into it?
Well, I trained at Yale in the 1960s, in the golden heydays of the Yale residency. I trained with Nathan Case, Bob Glass, and Leon Spiroff, three of the great leaders in infertility and reproductive endocrinology of not only that era, but even up to now. Dr. Spiroff is still the editor of the textbook on reproductive endocrinology.
I mean, these are the big names in the field.
Yes.
What was it like to train with these people? Did you know at the time they were the names, or were they just part of your training?
When I first started at Yale, Nathan Case was junior faculty, and Leon Spiroff was a resident, and Bob Glass was also very junior faculty. But as time went on, it was very obvious that they were really the people in terms of reproductive endocrinology. Their first textbook came out when I was a resident, and indeed I edited the first drafts of the first galleys for grammar.
This is pretty cool that you got to train with these people. So you were in Connecticut for many years, and then what had you come to Boston?
I was asked by Dr. Emanuel Friedman, who was then the chairman of the Department of OBGYN at Beth Israel and one of the professors at Harvard Medical School, to set up an infertility program for Beth Israel Hospital.
Got it. So you came to Boston, you set that up. Can you talk a little about, I mean, you trained in a time where there was no fellowship in reproductive endocrinology and fertility. It was developed as you went along, yes?
That's right. Okay. It was developed as I went along. I think the first infertility fellowships were set up near the end of my tenure at Beth Israel Hospital in the mid-1970s.
And when you came to Boston, did you have to create the program from starting fresh?
Oh, yes. We had to build a reputation as a place for doing infertility. We had to introduce to everybody the kind of medications, the kind of treatments, the kind of surgeries that were available then, and make it known that we could do them and do them well.
So I think people, when you talk about the fertility process, have a lot of questions. So if a patient were to walk in and say, I haven't been able to get pregnant, what are the things that you're looking at with that woman?
Well, you're looking at first her history in terms of when she started to have periods, how regular her cycles are, has she ever had any pelvic surgery or any history of pelvic infection, who is her partner, how old is he, has either he or has she been involved in any other relationship during which they could have conceived, and frankly, how often do they have intercourse?
One question I always say to my patients, although it's a little bit explicit, is do you actually have intercourse? And are you using any kind of barrier protection that would prevent fertilization? Because some of my patients will say, oh no, we don't do that.
Oh yes, that's always a question. Are you having intercourse? Have you been having it regularly? And the barrier about which we usually speak is lubrication, because most of the lubricants that are on the market are spermicidal.
Interesting. So are there any brands that you know of off the top of your head that are not spermicidal that our listeners could use?
One particular lubricant called Pre-Seed, that's available nowadays in most drugstores, that is non-spermicidal, but most of the others are.
Interesting. So you would say to your patients, don't use a lubricant. What about mineral oil? Is that?
Probably you really want to rely only on saliva or a lubricant such as Pre-Seed.
Okay. All right, so you've done the history with the patient, you've looked at what the indicators are. A lot of people have questions about what's covered, what's not covered, and what does a fertility workup involve?
In the 1980s, if I recall correctly, while I was chairman of the board of Resolve, we managed to get through the Massachusetts legislature the first mandate on infertility coverage. And so consequently, in Massachusetts, 2 out of 3 individuals are insured and covered for all kinds of infertility treatments, including in vitro fertilization.
This is very nice, because this is, or could be, an expensive process.
It can be a very expensive process. Just one IVF cycle costs approximately $13,000 in Massachusetts if you were paying out of pocket.
Okay. But that's covered for many people at some portion, if not all, usually?
Almost all is covered for most people in Massachusetts. There is one caveat, and that is some policies of medical insurance in Massachusetts are administered in Massachusetts, but not written in Massachusetts. For instance, if you work perhaps for a motor company such as Ford, you might very well be insured out of Detroit. But Blue Shield here administers it. They're not obliged to follow our mandates, whereas if you had your Blue Shield policy written in Massachusetts, you would be insured.
So you have to check your insurance policy?
Everybody does.
Okay. Now people say, oh, I don't want to do the shots. What do the shots entail? And what does it mean to get the shots?
For some individuals, you need to use injectable medications in order to stimulate ovulation, whether you're stimulating ovulation alone or whether you're stimulating ovulation as part of an in vitro fertilization cycle.
Okay.
They're subcutaneous injections. That is, they're shots that are just given under the skin with very tiny needles. And nowadays, the dosage is even measured for you. All you have to do is basically put this little tiny needle in the skin of your abdomen to give yourself the injection.
So this injection can stimulate ovulation, and if it does so, are you stimulating a lot of follicles? Are you stimulating one or both?
It depends on your purpose. That is, if you're doing in vitro fertilization, the name of the game there is to create as many mature follicles and mature eggs as possible so that you only have to do the procedure once and can freeze any surplus of eggs and embryos that are formed. If you're doing a cycle where you're not doing in vitro fertilization, then you want to be very careful in that you only want to stimulate one or two follicles to reach full maturity, lest all of the eggs that are produced end up being both fertilized and implanted and as ongoing pregnancies.
We've heard stories about these people, I think. There's TV shows about them now, right?
Oh yes, there are TV shows and they make the tabloids when they do more than one.
So I have a whole bunch of questions from what you just said, because I know about you that you pioneered the single embryo retrieval for IVF, correct?
That's correct. About 20 years ago, looking at what the cost of in vitro fertilization was, looking at people's reluctance to carry a multiple pregnancy, and the fact that the in vitro fertilization techniques of that era emphasized creating as many eggs as possible, putting in 2, 3, and 4 embryos every time that you went through a cycle in the hope that at least one would take and hoping that all 3 or 4 didn't take. Working with a French embryologist, devised a procedure called natural cycle IVF, or we called it NORIF in that day, in which we monitored a woman's cycle, determined almost to the hour when she was likely to ovulate or produce an egg spontaneously, and then actually in our office retrieved the egg in the same technique as you use for in vitro fertilization with a single needle puncture, and then fertilized that egg in our office and allowed the woman to incubate the egg by carrying it in a little test tube that was placed inside the vagina with incubation media. And then 2 days later, when an embryo had been formed, we would transfer that embryo back into the uterus in the standard fashion. The big advantage of this procedure was we didn't have to worry about did we have the best possible egg of the cycle.
Right.
We'd allowed that best possible egg to be selected naturally. The patient did not have to worry about the possibility of a multiple pregnancy. We only had one embryo, and we always had a quality embryo.
So tell me a little about, when you mentioned it's done in the office, are the retrievals normally done in some kind of procedure unit?
Most procedures involving usually the retrieval of a dozen or even 20 eggs are done under very heavy sedation in an operating room.
Okay, so there's a recovery associated with this.
Right.
When you're talking about an office procedure, you go in, you might have a little cramping, you go home.
That's right.
Okay. All right. So it's easier, quicker, cheaper,
Right.
faster.
Yes.
Okay. So now I have another question about the retrieval. When you're retrieving, if we're going back to multiple follicle retrieval, and these are frozen, they're then fertilized and frozen. Are these good quality? Does the freezing do anything to them?
Well, yes and no. What happens during standard conventional IVF is multiple eggs are retrieved through a transvaginal procedure. The eggs are fertilized with the partner sperm, and then the embryos are reviewed, and when you decide how many of these embryos are of good enough quality, you take the 1 or 2 best and transfer those into the uterus at 3 days after the egg retrieval took place. The other embryos are frozen. Most embryos of good enough quality that are frozen do indeed survive the freezing process, and probably 2 out of 3 survive the thawing process as well. So in the best of all possible circumstances, you conceive with your first IVF cycle having only accepted 1 or 2 embryos, and you have 5 left frozen that you can use every time you wish to try again for a second or third child.
So it makes it cheaper because you have this frozen.
Right.
Okay.
And better yet, they're frozen in time. In other words, it's always easier to conceive when you're younger, and therefore you can conceive at 34 and have embryos that were created when you were 34 who have as much chance of success when you're 36 or 38 as if you were still 34 at the time.
So let's explore that, because I still have more questions about the other, but let me ask you about that. So women are always quite concerned when they're sitting in my office about their fertility, and I always try to reassure them, you should pick the right partner as opposed to any partner. But yes, your fertility is starting to decline. Is there a line in the sand where you say, oh God, forget about it?
Well, we never quite say forget about it, but by the time you hit 38, your fertility is beginning to diminish. By the time you hit 40, it's going down much more rapidly. Usually by after 43, you're talking about low single digits in terms of conception. And so there basically is a sotto voce, an unspoken kind of rule, and sometimes actually spoken, that many fertility clinics here in Massachusetts will not accept patients after their 43rd or 44th birthday, nor will their insurance company underwrite the costs of doing in vitro fertilization. But we try to individualize. You check someone's blood levels at day 3 of their cycle to see how hard their pituitary has to work to kick off a new cycle. If it doesn't have to work very hard, then you think there's a fair amount of healthy follicles left within the ovary that are capable of maturing and releasing a healthy egg. If the pituitary has to work excessively hard to start a new cycle, no matter what your age, it means that the reserve of healthy ovarian follicles has been diminished significantly, and the chances for success with any kind of fertility procedure, be it simple ovulation induction or IVF, are significantly, substantially diminished.
Are there things that women can do to improve their fertility and their chance of conception?
Well, there's one new thing. People can nowadays freeze their eggs, which used to be an experimental procedure, but in the last 2 or 3 years has now become something that is available widely and is being covered by insurance in some cases. Not always, but in some. But in general...
These are unfertilized eggs.
Right.
So these are women who are unpartnered and say, I want to increase my chances for later.
Yes, that's exactly who that is.
And do the eggs survive the freezing and thawing cycle?
Again, not so well as embryos do, but yes, they do.
Worth doing.
Worth doing.
So it's an enhanced cycle. It's not a single egg retrieval. It's multiple
yes.
eggs. Okay. So those are women who would need to do the injectables and stimulate an ovulatory cycle.
In order to prepare for egg retrieval, you have to follow the same path, whether you're going to use those eggs in that cycle or freeze the eggs, and that is take hormones to induce multiple ovulations so there are enough eggs created.
Are there sites in Massachusetts who are providing that service too?
Yes, I think most of the IVF clinics are beginning to do so. Certainly Reproductive Science Center, the one with which I'm affiliated, does.
Okay. And what else can women do to improve their fertility?
They can eat a healthy diet. They can maintain a healthy lifestyle in terms of exercise. They can avoid smoking. They can exercise regularly. And
what about weight loss or stress reduction? Any of that really make a difference?
Well, weight loss to a certain extent. One likes to have an ideal sort of body image, or rather body mass index. Ideal body image may differ a little bit from body mass index.
The eye of the beholder.
Right.
And then stress reduction. I know there's a lot of conversation around go to acupuncture if you're trying to get pregnant, go to massage.
There certainly is data to suggest that in vitro fertilization cycles and ovulation stimulation cycles, women who do acupuncture actually do better. But is there data to really support the idea that, well, the principal route to fertility would be to do acupuncture? No,
Not sure.
not really.
So let me ask this question then. When you were talking about, I just forgot my question, but it had to do with, I know, multiple embryos that are implanted. Is there a difference in success rates between implanting 3 or 4 embryos versus 1 or 2?
Yes, there is a higher success rate if you implant more embryos. On the other hand, there's a much higher multiple pregnancy rate. And while having twins is exceedingly difficult compared to having one at a time, since you're always dealing with 2 practice children rather than 1, having triplets and having quadruplets can be extraordinarily difficult both as a pregnancy. Prematurity is often a complication, and those infants don't do as well as singletons or even twins.
I mean, I know the average age of delivery for twins is around 36 weeks. For triplets is in 28?
It's about 32 weeks. For quadruplets, it's about 28 weeks.
Okay, so now we're talking significant prematurity.
Right.
Right. With possible complications of prematurity, cost in the hospital, and then you actually have to care for them at home.
That's right.
Okay. Is the divorce rate higher in people, do you know, who have had higher order multiples compared to singles or twins?
I don't know that answer. Okay. That's a good question. Certainly the divorce rate has always been an issue even in infertile couples. Sometimes that's the deal breaker. And we think of that as in third world cultures where the role of a woman is clearly just to produce children. But even here in America, there's an issue. And certainly I remember talking with a Serbian rowing coach here who said in Serbia, if a woman can't produce children, she's divorced.
Got it. What about surrogacy? Is that something that you work with patients at all in?
I don't personally, but surrogacy, with 1 or 2 exceptions, surrogacy is indeed an issue for a woman who really cannot carry a pregnancy. But sometimes what is done then is a woman will go through the IVF process to prepare embryos, and then those embryos are transferred and put inside another woman's uterus for that woman to carry the pregnancy. In Massachusetts, there are no binding surrogacy contracts, and so it's not a practice commonly done here in the United States.
And what about egg donor, in which another woman donates the eggs for a woman who's not producing eggs?
That's a much more common procedure. Indeed, that's really a standard of care in someone who has gone through premature menopause, let us say, who cannot produce her own eggs, or for having been treated with some kind of anti-cancer medication, chemotherapy, and therefore is not capable of producing eggs. That sort of woman could very well carry a pregnancy provided a suitable embryo were created. And in that instance, one uses donor eggs and fertilizes those eggs, usually with the partner sperm.
Is that typically something that's covered, or is that outside the boundaries of fertility coverage?
No, actually in Massachusetts, if you're defined as infertile by your insurance company, and that's the big if, it is covered. A woman who went through premature menopause or for some reason or other has reduced fertility before the age of 38, who needs donor eggs in order to become pregnant, if she has infertility coverage, she's likely to have coverage for that procedure as well. But what coverage means is it pays for the costs incurred by the donor, the medical costs incurred by the donor. It doesn't pay for any legal costs, it doesn't pay for any transportation costs, but it pays for the donor's costs as if the individual were the same person producing the eggs as is going to use them.
And are donors typically compensated above and beyond their medical costs and time off of work?
Yes, they usually are, unless it's an identified donor. If one's younger sister wants to donate eggs, you probably would not be compensating her above and beyond.
Mm-hmm.
If it is some recruited anonymous donor, then yes, there's usually a fee. Nowadays, with the capacity to freeze eggs, it's quite possible that those costs will go down because you really will not necessarily be creating a new set of eggs each time you want to do an IVF cycle. Mm-hmm. It'll be a little bit more like using donor sperm, where there are sperm banks that store sperm, and you just purchase the sperm from the sperm bank.
Are there any long-term risks to either the induction cycle or doing this multiple times? If women were to become egg donors and have egg banks, anything about that? Long-term?
In the 1990s, there were several widely publicized articles to the effect that taking fertility drugs puts you at risk for ovarian cancer later on in life. Those articles were afterwards rebutted, and their basic premise was essentially withdrawn. There does seem to be a slightly higher incidence of ovarian cancer among infertile women whose infertility has to do with their inability to respond to ovulation induction or to ovulate spontaneously, probably suggesting there's an underlying ovarian problem of which infertility is one aspect and the increased risk of cancer another. But as far as using the drugs we use to stimulate ovulation, the NIH has conducted studies ever since IVF became available and has documented that there is no increased risk.
So it's not actually the drugs, it was the underlying infertility that raises a woman's risk slightly for ovarian cancer later in life.
That's right.
Got it. And is there any evolving legal work that goes on? Should there be egg banks, basically?
Well, there are always ethical issues about this. There always has been a concern that wealthy individuals would take advantage of those who would be willing to donate eggs only because they desperately needed the funds that they would be paid for doing so. And so there has been an argument on and off for 20 years or more about either are surrogates selling themselves because they need money? Are women willing to sell their eggs because they need money? Are they being victimized for the sake of those who are wealthier and can afford to purchase eggs or to purchase a surrogate uterus, so to speak? Generally, I think there are many, many safeguards nowadays in terms of the American use of donor eggs or surrogacy. I don't think people are being exploited. I think really what we're trying to do is fill a need for women who could not have a pregnancy or build family otherwise.
And what about the possibility that one day you could marry your genetic sibling because of an egg donor or a sperm donor? Is that anything being looked at? Or
the American Society for Reproductive Medicine easily 30 or some odd years ago set out guidelines that no one would ever use a single sperm donor to create more than something in the order of a half a dozen pregnancies in the lifetime of that donor. Similarly, there are guidelines being created in terms of egg donation as well. So the likelihood of genetically related individuals unknowingly marrying one another is minimal.
Okay. And do they also take, for sperm or egg donors, do they take a blood sample to look for common genetic malformations?
Yes.
So you can know what you're getting?
Donors are vetted very carefully in terms of their overall health, their parental health, their family histories, the history of any congenital anomaly, and nowadays people are beginning to do the same kind of chromosome analyses that we're beginning to do for ourselves as individuals when not considering this procedure.
When When patients come in to see you, do they need to bring their partner along, or can they come alone, or what works best?
It's always a good idea to bring your partner. You want both members of the couple to really be there up front, to go over their individual histories, and to know what's being said. There's nothing so frustrating as being the absent member of a couple and relying upon the other person to tell you, well, what did the doctor say? What should we be doing? Is that really what he or she said and told you? And of course, when you're a patient sitting in a doctor's office, it's to be hoped you understand exactly everything we've said and told you and written you. And the answer is 2/3 of it probably is not quite construed correctly.
Yeah. So you do recommend people bring their
do.
partners? Okay. And we're coming towards the end of the show. Is there anything that I missed asking you, or anything that our listeners might be interested in that I just totally skipped over?
Well, we talked mostly about fertility, but certainly at Visions and in my own practice long before that, I've been interested all the time in the functionality of endocrine activity, in the interrelationships between what the ovaries do, what the thyroid does, what the pituitary does, and what the adrenal glands do.
So you treat a lot of menopause and thyroid disorders also?
Yes, I do.
So you see women of all ages?
I see women of all ages. I deal with even adolescents and adolescent irregular ovarian function, with people approaching menopause, with women after menopause, with women who have PMS, and with a fair number of thyroid and pituitary and adrenal problems as well.
I know a hot topic today is bioidenticals. Do you also do bioidenticals?
I do use bioidentical hormones, but by bioidenticals, I mean estradiol and progesterone, the hormones your body produces. Sometimes I use compounded preparations of these, and sometimes I use the commercial preparations. I generally stick to those rather than the synthetic estrogens and progesterones that are in birth control pills, for instance, except when I'm using them for birth control.
Right. Okay. Did I miss anything? This was extremely interesting. And I think we've sort of scratched the surface of fertility and infertility, and we haven't even gone near other endocrinology questions like thyroid. I know everybody thinks their thyroid's low. But did I miss anything major? Because we're about to end the show.
Well, I think we've pretty much covered it all. It's just important to understand when you talk about a woman's endocrinology, it's a little bit different from a man's, and that things are interrelated. When you alter the way the ovaries are functioning, then you affect the pituitary and you affect the thyroid and you affect the adrenal gland. And when you alter the way those two are functioning, you similarly affect the way the ovaries and pituitary interact.
This has been extremely interesting, Dr. Gross. Thank you. Thanks for joining us for another issue of Visions for Health.